I have the privilege and pleasure to share with you over the next 10 to 15 minutes the development of catheter ablation of atrial fibrillation over the last 20 years. And when you take a look to the literature that has been published in 20 years, you end up with more than 10,000 publications around the field of catheter ablation. You may understand that it's very difficult in 5 to 7 minutes to concentrate on the key publications, but I think I picked those that really paved that way, that journey to achieve something like cure for patients with atrial fibrillation. And it brings us back to times where the three of us were a couple years younger when Jimmy Cox published this amazing paper. I can recall that I had just finished medical school when I read this paper from Jimmy Cox, who introduced for the first time a therapeutic approach a curative approach to patients with atrial fibrillation, a definite therapy. And this was so important as it opened up the interest of interventional cardiologists to achieve effective interventional therapies for patients with atrial fibrillation. The slide summarizes the Maze 3 procedure, which was a complex cut and sew procedure for patients with atrial fibrillation based on the animal experimental mapping studies that Jimmy Cox, as a cardiac surgeon, performed in the early 90s. It consisted of pulmonary vein isolation, very important to recognize that even in that first concept, pulmonary veins were isolated, but also mass reduction on both atrial sides by the amputation of the left and right atrial appendage. So Cox and co-workers were able to prove that with such a complex but very effective surgical procedure, the recurrence rate of atrial fibrillation post-procedure could be dropped almost to zero. The next amazing study was then delivered a couple of years later, and I always call that the forgotten contribution, as the contribution of John Schwarz to the development of catheter ablation strategies, to me, has never been appreciated much enough. John Schwarz was the first interventional electrophysiologist who had the idea and the courage trying to replicate the Cox-Maze procedure in principle with electrode catheters in human atrial fibrillation. It was really amazing when John Schwarz presented these data during the American Heart meeting in the late 90s. And unfortunately, it never got fully published, but it stimulated several groups in North America and in Europe to take this idea further and to explore ways to better understand atrial fibrillation with the ultimate goal to develop curative therapies that can be delivered not only with a complex open heart surgical procedure, but with a catheter-based procedure. And this study clearly is the major breakthrough in the field of catheter ablation of atrial fibrillation. One of the most beautiful papers in interventional electrophysiology from all fields. When Michele Hisagi published this paper, supported by his superb group that followed initially the lines of John Schwarz and trying to replicate a maze-like procedure with catheters, and then observed that focal sources may play a key role for the induction of atrial fibrillation. Initially, they believed that these sources would cluster in the right atrium. That was the initial description. But then, when they went deeper into the procedure, they recognized it's the left atrium and it's the pulmonary veins that work as drivers, triggers, sources for atrial fibrillation, and they could, for the first time, very nicely show that these triggers very, very aggressively promote atrial fibrillation. And they could also show that when these triggers are eliminated by means of catheter ablation, the likelihood of getting atrial fibrillation dramatically decreases. The initial approach of pinpoint spot-like focal ablation of atrial fibrillation was then modulated to pulmonary vein disconnection procedures, and then finally, and this is a contribution from a group from Italy, from Carlo Papone, transferred to 3D navigation guided isolation of the pulmonary veins. This is from the publication of the group from Carlo Papone. They for the first time showed that with the support of the 3D navigation system, you can reliably isolate the pulmonary veins. This is the contribution of Karl-Heinz Cook and his group. They took the same approach, and they could show that with a more electrophysiological guided approach, which they called the double lasso technique, which is depicted on the left side, and a targeted circumferential ablation approach on an atrial level, the pulmonary veins can be effectively isolated. One of the most beautiful tracings from the field of AF probably ever comes from that paper, as it shows electrophysiology, the beauty of electrophysiology, the pulmonary vein potentials, atrial fibrillation in the pulmonary veins with different degrees of conduction blocks from the left upper to the left lower, but the heart is in sinus rhythm, clearly showing that complete isolation of the pulmonary veins has a therapeutic potential for these patients. The same group made a significant contribution to the development of cryoablation for pulmonary vein isolation. Once it was shown with radiofrequency energy that isolation of the pulmonary veins is a cornerstone and a key achievement with a high therapeutic efficiency in that patients, it simply made sense just to explore other energy sources to achieve the same goal, complete pulmonary vein ablation. This paper is so important because it combines clinical science with clinical education. In this paper, it was nicely shown that with a simplified approach, without additional screening, without pre-procedural imaging, with a single 28 millimeter cryoballoon, in most patients, the pulmonary veins can be effectively isolated. Why I like this paper especially is that aside from the scientific value and progress that it induced in the field, it gave very practical hints and evidence how to cope with difficult anatomies in order to achieve solid and reliable pulmonary vein isolation using a cryo balloon. And this is depicted on the right side of this slide, where they nicely showed with different anatomies you may need different approaches when it gets difficult to isolate the right lower pulmonary vein. Over the next 10 years, there was a significant application of different techniques exploring what we may need to do on top of pulmonary vein isolation in order to achieve even more therapeutic effects. And there was the introduction of the ablation of complex atrial fragmented activities, the so-called CAFE ablation. There was the introduction of linear lesion ablation, either based on anatomic, predefined lesion sets or related to some forms of either electrophysiological or structural abnormalities, and also the deployment of clusters of lesions in order to reduce the likelihood of AF recurrence following an ablation. The StarAFII trial, which is depicted on this slide, for the first time analyzed 3 different treatment strategies: pulmonary vein isolation or approach pulmonary vein isolation alone, or in combination with linear lesions or with so-called CAFE ablations. And on the right side, you see the Kaplan-Meier curves after the blanking period, recurrence of atrial fibrillation in the 3 groups: pulmonary vein standalone ablation, pulmonary vein plus CAFE ablation, and pulmonary vein ablation plus linear lesions. And as you can see, at least in the setup that was investigated by Atul Verma and the group, there was not that much of a difference and not that much added value by extrapulmonary vein ablation techniques and approaches. I would like to close my journey through the field of development of catheter ablation of atrial fibrillation by sharing with you a remarkable study which has been presented as one of the big bang studies during the last ESC meeting in Barcelona, when Nasir Marouche presented the results of the Castle AF trial that was awaited for a long time. It's still not fully published, so we can share with you only some of the key data as presented there during the oral presentation. Castle AF focused on the effects of catheter ablation of persistent atrial fibrillation in patients with advanced heart failure. All patients included into the trial needed to have a cardiac implant, most of them a defibrillator implanted. So out of 3,200 patients that were screened with advanced heart failure, I think it was ejection fraction less than 35%, plus an implant, mainly a defibrillator on board. Finally, roughly 400 patients were included and were randomized into two groups. One group received optimal medical therapy and followed up by the cardiac implant, while the other group received optimal medical therapy plus catheter ablation of atrial fibrillation, also followed up by the cardiac implants. And the results of that trial are really remarkable and exceeded my expectations, as it was shown that there was a positive impact of catheter ablation of atrial fibrillation in this advanced heart failure patients with almost every outcome that was addressed in this prospective, randomized, high-quality, multi-center trial. Most remarkably to me was not only that the recurrence rate of atrial fibrillation was significantly reduced, which was included in the primary endpoint, but also that there was an almost 10% increase in left ventricular ejection fraction in patients that underwent catheter ablation. And that led to a reduction in total mortality, which was really remarkably, I think, almost 40%, and also to a significant reduction in rehospitalizations and accordingly to a reduction in cardiovascular mortality. This is a very important trial, as the trial shows that we can do something and achieve something on top of optimal medical therapy in patients with advanced heart failure and persistent atrial fibrillation. Thank you.
Thank you very much, Gert. Let's stay with Castle AF for a moment. Karina, I know you can address the apparently highly selected group of patients considering the numbers screened. Can you explain that for us?
Well, there were 3,000 patients screened, and one may wonder how selective were these 400 patients. But it's not difficult to explain, because an inclusion criteria was that patients included should have either a CRT or a defibrillator with an atrial lead. So they had to screen a lot of patients, of course, because many of them were excluded if they didn't have that.
It's important to know, because one always worries about such a difference between numbers screened and numbered entries, so that's a good explanation. We all recognize that this is an important recent study. What do you think the implications are going forward, Gert?
I think the implication of that trial is that we need to go further with additional clinical trials. This is just a single prospective randomized trial, that we should go further with clinical trials well designed into the field of heart failure and atrial fibrillation. If we look to the disease statistics, two endemics are leading the field. One is heart failure and the other one is atrial fibrillation. And in many patients, they go hand in hand. Mortality is still high in this patient population. Treatment opportunities are limited. Antiarrhythmic drug treatment, there's only amiodarone, which has a tendency to induce overmortality in most patient settings that we know. So it really opens up a new new hope and new therapeutic window for heart failure patients with atrial fibrillation. It's a very important trial. The AMICA trial is a second prospective randomized trial that we are awaiting, hopefully for the next year.
Okay, anything to add?
Well, I think one may wonder how to select these patients already today once this study is published. Even though the patients referred for ablation had symptoms of AF, how can you differentiate AF-related symptoms and heart failure-related symptoms? That's the first question. My second question is, should we refer patients with heart failure and AF without obvious symptoms of AF related to the fact that you improve mortality and you reduce hospitalization?
It's a very important point as it opens up the discussion about the outcomes that we are approaching with our therapeutic intervention. And I fully agree with you. While in patients with normal or slightly reduced ejection fraction, quality of life is the key outcome that we would like to affect with our intervention with catheter ablation in this patient population. It may be different. Honestly, I don't believe that this trial is strong enough to change the whole field, but it opens up widely a door for earlier application of consideration of catheter ablation in patients with heart failure, as the mortality in this patient population is really high. And there is another significant information as far as I've seen the data that related to the risks and complications related to the interventions. They seem to be reasonably low, although these patients were in advanced structural heart disease.
They were comparable to other ablation studies, so there was no difference.
Yeah.
And I think one important message here is that it's the first study which has used mortality as primary endpoint. And it shows a benefit. Well, it's a combined primary endpoint, mortality and worsening for hospitalization. So, but standing alone, total mortality per se also improved significantly in the ablation group.
I always think it's the sign of a good study when it generates even more questions going forward.
Yeah, that's true.
Let's go back to StarAFII, and we have some concerns there. I know, Carina, you have some concerns. Would you like to explain those? Yeah,
because the StarAFII trial, the design is a bit questionable, because here we are asking ourselves, is it worthwhile doing lines? Is it worthwhile adding catheter to pulmonary vein isolation before we have proved that we have complete PV isolation? So this is the first remark. Second, if you cannot create complete lines that are durable, you cannot evaluate the value of actually creating lines.
Yes, that's
so there are two questions.
That's my concern with this study, is that the conclusion is that lines don't add anything. But
we don't know.
My conclusion is that we can't draw lines properly, and that's why that's made no difference. So we have to have open minds about that.
But if you review previous trials using lines, catheter and so on, and also the PV isolation studies, you can see that once you have a population with complete PV isolation, the recurrence rate is only 5 to 8%. So if we can have a technique that creates durable, long-term, complete PV isolation, we can cure the majority of patients.
Paroxysmal AF.
Paroxysmal AF, 92-95%. But many of patients had also persistent, if we exclude long-standing persistent. So it's my belief that PV isolation is actually the treatment of choice.
I would fully agree to that. It remains a cornerstone. And just to give the credit to Atul Verma, we have to understand when we look at StarAFII that these trials are completely, they're very difficult and complex to set up. I believe it's a 6-7 year period from the idea until the publication of the trial. By the time it was designed, the points that you for good reason made, Carina, were not so obvious, that the durability, the stability of pulmonary vein isolation is one of the cornerstones of effective therapy, and also the issue of the completeness of lesion lines was not so clearly in our scope. If we compare the results of StarAFII with meta-analysis that looked to smaller studies that compared additional extrapulmonary treatment strategies, the outcome was roughly the same. So none of the extrapulmonary vein ablation strategies that was evaluated so far gained importance enough to be mentioned in the guidelines.
I think we're agreed.
Mm. Yeah.
Time to move on to your next few slides, Gert,
yeah.
on the technology.